Welcome back. Let's talk about the mouth and the esophagus. So at this point, we are looking to ingest our food and it's going to enter the oral cavity. So let's learn about those structures in the oral cavity and the pharynx. We have the lips and the cheeks and our facial muscles, which are trying to keep that food inside our oral cavity, not between our cheeks and our teeth like in chipmunks, but more on the other side of our teeth. If we look, we have a hard palate at the top and then it goes to the soft palate, and then hanging down, we have this little thing in the midline that is known as the uvula, which is going to be very important at closing the space, the opening between the nasal pharynx and the oral pharynx so that food and drink do not go up into our nasal cavity. We also have tonsils here on the sides of our mouth as well as the back of our tongue. And our tongue also manipulates the food and is going to kind of compress it into a little ball. All of these parts in our oral cavity, as well as in our oral and laryngeal pharynx, have this type of epithelium. So the basement membrane is down here, and so you can clearly see it's more than one layer. So it's not a simple epithelium, it's a stratified epithelium. And as you recall, we named stratified epithelium not by the shape of the cells here at the basal layer, but the shape of the cells here at the apical layer. You can tell this is the apical layer because there's the surface with no more cells, and these cells are the flat cells. So what was the name for that cell type? And then you know the type of epithelium this is. And so in the oral cavity, all the saliva and the tongue are going to work together to create a ball of food known as a bolus that's going to be covered with saliva, and the tongue will push it posteriorly towards the oral pharynx. So let's talk about your teeth for a second. We had 20 baby teeth, but as adults, we have 32 permanent teeth. And so if we do 32 teeth, we've got 16 on top and 16 on the bottom. But if we divide it right and left, that means we have the same 8 in each of the 4 quadrants. And of the 8 teeth, we have 4 different types of teeth. So you would think, oh, we have 2 of each type, because that would be easiest, but that's not how it works. And I'll tell you where the differences are between the 20 baby teeth and the 32 permanent teeth. So looking at the permanent teeth, the first 2 on each side are the incisors. When you look at the top of them, they come up and they're very narrow. They are meant to cut. So we have 2 incisors on each side, just like the babies do. And if you don't believe they were sharp, put your finger inside a baby's incisors and they can cut your finger all the way down to the bone. And these are meant to cut things like carrots and any kind of food that you were eating. As we move to the side, the next tooth, the next one tooth on each side is pointed, and it's called a canine, the word for dogs. Dogs have this pointed tooth, so do alligators and crocodiles, okay? This tooth is meant to grab onto stuff and rip it. Okay, so when you see a dog grabbing onto a toy and you can rip it from them, they're grabbing on with their canines. Working our way posteriorly, the next 2 adult teeth are called premolars, and children don't have these as baby teeth. The premolars come in middle school. The first one comes in around age 10 or 11, and the second one comes in around age 12. And so you only have 1 set of premolars. If you look at the premolar, it's a little bit pointy, kind of like a canine, but the big difference is, as opposed to a canine, which is just pointy and is scooped out and back, the premolar has a flatter back. So it does more than just grabbing on. It can do some grinding as well. And it has a bigger root to it as well. And then the next 3 teeth in adults are molars, and in children, there were only 2 of these. And these have very flat surface. And I don't mean flat as in they're like this, because you can see that they're up and down little mountainous teeth, but these are our grinding teeth, very good for chewing vegetables and fruits and things like that. The third molar is the tooth that you think of as your wisdom tooth, because it tends to come in between ages 16 and 20, about the time you graduate from high school, when you're supposed to have all that wisdom. All right. If we continue to look at your tooth, the part of the tooth that you can physically see is called the crown of the tooth. And then the part that's embedded in the gum and in the bone is the root of the tooth. And let's look a little bit more at tooth structure. If you look at this tooth, you can see most of this tooth is made up of this brown substance. Okay. And if you think of the word for tooth, the root is dense, because you go to a dentist. So this brown substance is called dentin, and it's super hard, like bone hard, okay? And then so this is both in the crown and in the root. Now, the dentin that is in the crown is covered with something that is calcified, and that is enamel. And you really want to brush your teeth well, because sugar feeds bacteria who will leach acid that can create pits and holes in your enamel, and that's what cavities are. So if you have cavities, you want them treated while they're still in the enamel before they get into your dentin. Because if they start eroding through your dentin, they can get into this area right here, which is a space filled with connective tissue known as the pulp cavity. And this pulp cavity extends into where it is known in each root as the root canal. And in the pulp cavity and in the root canal, we have blood vessels and nerves, which are bringing nutrition as well as innervation to this tooth itself. So you can see that if you had a cavity which went all the way through the enamel and dentin into the pulp cavity, it would be extremely painful. The same thing if you had a fracture in the root of a tooth, then the air would be exposing the nerve, and that's extremely painful. And that's why people get what they call a root canal, which is when a specialized a dentist who has done even more training goes in and removes all this connective tissue that's in the root canal, and fills it up with other inert material so that the nerve is no longer exposed and can get rid of that pain. Whew. All right. Now, also in your mouth, we have our first accessory organ, the salivary glands. And we have more than just one salivary gland on each side. We actually have 3 salivary glands on each side. And each salivary gland actually secretes something slightly different from each other. And you don't need to memorize what each one does specifically, but rather learn what they do as a whole. So the first salivary gland is right here in front of your ears on each side, and sometimes they get inflamed. And this is known as the parotid glands, and you usually can kind of feel it. All right, and it has a pretty big duct, and if you open your mouth and you look across your second molar and you squish your parotid gland, you usually can see the fluid coming out of it. The second salivary gland is called the submandibular gland because it is below your mandible. So the mandible, so if you go back here where your mandible meets right here at the angle of the jaw and you go just on the inside, that's where this gland is. Okay. And then the third salivary gland is under your tongue. So bring your fingers forward and then to the midline. And that's where this one is. So this is the parotid gland, and this is the submandibular gland, and this is the sublingual gland. Okay. And so what the three salivary glands do is they secrete saliva. And so there's a lot of really cool stuff in saliva. Okay. So it's mostly water, yes, but if you've ever felt your saliva, you know it's slimy, so it contains mucus. But that is not just slime and water. There's antimicrobial substances in there. You don't need to know the names of it. But in other words, your saliva is real important at cutting down the number of bacteria in your mouth, unless you're an open mouth breather, in which case your saliva dries up and you're more prone to getting cavities. It also has bicarbonate to get rid of the acid effect. Remember, I said the bacteria are producing acid, so it's trying to neutralize the acid being produced by the bacteria in your mouth. And most importantly, it produces an enzyme known as amylase. So you remember from way back when we were talking chemistry, if it ends in ASE, that is an enzyme. So we'll be talking about this shortly, as in on this slide. So the functions of the oral cavity. So the first function is mechanical digestion, as in we are going to be masticating, which is the scientific term for chewing, opening and closing your mouth using your teeth and taking a piece of food and making it into smaller pieces. So what's the point of taking something big and making it into smaller pieces? Well, if something is this big, then this is the surface area right here. So if we came with chemicals, chemicals can only attack the surface. Whereas if we took this and we chewed it up into a whole bunch of pieces, each of which was this size, this would make about 30 of these, and each of these has a surface. So there was a lot more surface area available for the chemicals to act on. So that's the second function that's going to start in the oral cavity, and that's chemical digestion. So that enzyme amylase coming from the salivary glands starts carbohydrate digestion. All right. So I will have a video later on, which is talking about all the chemical digestion that is going on, where I'll put it all in one place for you. Okay. So once we have the bolus in our tongue and it's all covered in saliva, it's time to swallow. And so what's going to happen, that uvula that was hanging back, that's going to raise and block the opening between the oropharynx and the nasopharynx above it. If you remember when we learned about the larynx, we had the epiglottis, which was elastic cartilage. That's going to close the opening between the laryngeal pharynx and the larynx. And so that food bolus is not going to drop into the larynx and the trachea. Instead, it's going to have to go into the esophagus. Now, we know, everybody swallow. This is voluntary movement. So it must be skeletal muscle at this point. Okay, don't forget the basics we learned way back when, week 1. Voluntary movement means it must be skeletal muscle. Involuntary movement means it must be smooth muscle or cardiac muscle. We're not talking the heart and the digestive system. So anytime we're talking involuntary movement in the digestive system, it must be smooth muscle. Don't forget that. So here is an animation showing you yellow is the food bolus. And so look what is happening. We have the uvula already blocking, and then this white structure is the epiglottis, and you can see it flip down. So stay here if you need to and watch this several times until you can actually see what is happening clearly and you understand the movement. All right, so now we are in the esophagus. And remember, the esophagus is in the thorax. It goes between the laryngeal pharynx and the stomach, and we are posterior to the trachea and anterior to the thoracic spine. And although we have skeletal muscle in the proximal part of the esophagus, in the middle part of the esophagus, the muscle type is going to change because it's going to become involuntary. You know this if you've ever felt food get stuck right here behind your sternum, and no matter how much you swallowed, you actually just had to wait a minute or two and then the food went down. There was nothing you could do to make it move down. It's involuntary. Okay, so it changes in the middle of the esophagus. And here at the distal esophagus, when we reach the stomach, look what happens. We had that stratified epithelium. And all of a sudden, it became a simple epithelium. And notice these cells are not flat. They're very much, and they're not cuboidal. So they're that third type that's very tall with the nuclei all at the base. So this is a simple what type of epithelium? Okay, hope you have figured this one out. Okay, and so that happens, as you can see, very abruptly at the stomach. One other thing that happens at this junction between the stomach and the esophagus is we have a sphincter. So what a sphincter is extra layers of muscle there, of inner circular muscle there, that can contract really tightly to close the opening. So stop and think for a second. This is not to prevent food from entering your stomach, because that would be a bad thing, because you would be eating and then food would be piling up, and like on Thanksgiving, like you'd be vomiting food. So this is called the gastroesophageal sphincter, not the esophagogastric sphincter, because the point is not to prevent food from the esophagus from going into the stomach, but to prevent what's in the stomach, gastro, from going back up into the esophagus. Because if you look at what happens, this part of the stomach is actually higher than the lower part of the esophagus. See, the esophagus goes to here, and part of the stomach is actually higher, especially if you're lying down, especially if you're sitting up and you're eating your Haagen-Dazs, your chips or whatever, and the movie ends, and then half an hour you lie down, go to sleep. You do not want to wake up with a mouthful of food. And so you want that gastroesophageal sphincter to be closed and tight, so you don't have anything going back up into the esophagus. Now, how does food move down the esophagus? Well, it's not like a well where you take your penny and you drop it and it goes plop. It's not plop, plop, fizz, fizz. What happens is a movement called peristalsis. So say that word, peristalsis. And peristalsis not only happens in the esophagus, but it's going to happen in the stomach, the small intestine, the large intestine. So it's a term you need to know. It's going to happen everywhere. So what is going to happen is we are going to have alternating rhythmic contractions and relaxations. Remember, we had that longitudinal layer of smooth muscle? Well, it's going to contract here and relax, then it's going to contract here and relax, then contract here and relax. And by doing that, it's going to be moving the food down the pathway. Okay, so you can see it. So when that food gets stuck, it's just because you have a little spasm going on, and you just have to wait for it to relax, and then the food moves down. Peristalsis will continue. Okay. So have you ever heard of GERD? GERD stands for gastroesophageal reflux disease, what you may have called heartburn. Okay, so this is what happens when there's a failure of the gastroesophageal sphincter to do its job, and you have gastric contacts go back up into the esophagus. because as all of you know, there's gastric acid. The pH of gastric contents is 2. It's more acidic than lemon juice. And you know, lemon juice makes you pucker, make faces. So you basically are burning the lower part of your esophagus when gastric contents go into your lower esophagus. And so you'll get an inflammation. So if you go down with a scope and look at the esophagus, that stratified squamous epithelium looks very whitish, okay? And then here we've got a little bit of stomach down there. And do you see this red part? Looks kind of like a bad sunburn. Well, because you have sunburnt the esophagus. You've done the equivalent. This is a burn from this reflux of gastric contents into your esophagus. And if you don't treat this, if you say, oh, it's not that bad, I can live with it, go get treated, get evaluated. Because what can happen over time is the normal esophageal epithelium will change into a different type of epithelium, into that stomach and intestinal type of epithelium. And you have what's called Barrett's esophagus, which is this other looking epithelium. And this makes it much more prone to becoming cancerous with continued reflux going here. And here is an example of normal esophagus, the area of the Barrett's esophagus, and here is the cancer right at the junction. And your chances of this happening are much increased if you are a smoker. That includes vaping and that includes pot. Or if you have alcohol ingestion. Those are 2 big things that greatly increase the risk here. All right, I'm done with this section. Thank you, and I will see you soon as we come back and we learn all about the stomach.